It's the first day of April, marking the first day of National Sarcoidosis Awareness Month. FSR has partnered with the Chest Foundation for a year-long awareness campaign to educate all stakeholders and patients. We believe that all educated patients are empowered patients, so we congratulate all of you. Hopefully we're going to have about 400 people on the line, but we congratulate all of you for learning all you can about sarcoidosis. Also, thank you to Dr. Bob Baughman from University of Cincinnati for hosting the webinar. You can view his PowerPoint, the slides on the screen as he goes along. Remember that Dr. Baughman can't offer any personalized medical advice or advice in any way or guidance in any way. You should always see your medical provider. We'll also at the end be taking questions in the last 30 to 40 minutes. We've already received a number of questions, and we'll scroll as you submit online as we go along. Try to keep your questions relatively general, and again, without getting too specific about your needs. Please know we're trying to get to as many questions as possible, and we'll also take out any names of doctors or patients that appear in your typed questions. So all that being said, we're again grateful to Dr. Baughman for his support here, and take it away, Dr. Baughman.
Thank you, Ginger. I also want to echo the fact that this is a good month to start things off. The Sarcoidosis Awareness Month is something I think it's always important. I want to also thank Ginger and the rest of the group at the Foundation for Sarcoidosis Research for giving me the opportunity to talk to you a little bit. I will try to limit my didactic part, this first part where we go over the slides and the details, to about 30 minutes or less, so that we can answer any questions as we go along. Unfortunately, the way it's set up, you won't be able to ask me questions specifically, but please write them down so that you can get them in for as we go along. So my task is to talk a little bit about an update on sarcoidosis therapy. Next slide. Next slide. Okay. So I wanted to talk about the fact that whatever I'm going to talk about, I do have pharmacologic support for sarcoidosis. And that several of the drugs I'm going to talk about are based on studies supported by these various companies involved. Next slide. There are only 2 drugs that have been ever approved by the Food and Drug Administration for sarcoidosis. Both of them were only approved for pulmonary sarcoidosis. One is prednisone, and one is an old drug called Acthar gel, which I'm going to discuss at the end. Almost all patients are receiving drugs that are not indicated for extrapulmonary disease or indications, and therefore really what we're talking about is what's called off-label. This isn't that important to your physician because the physician is very used to the idea of giving drugs, especially to people who have rare diseases. This happens all the time in cancers. A drug is approved for one form of cancer and been shown to be successful in other forms of cancer. And so the physician is allowed to order these drugs even though it's not FDA approved for that indication. Sometimes when the drug is very expensive, your drug provider may not want to give that drug, and they may have to go things like prior authorization. Next slide. I want to think about sarcoid therapy as a pyramid, and I'm going to kind of discuss this pyramid as we go along. Every patient with sarcoidosis, as I see them, I want to talk about the fact that I observe them, and it may not have to give them therapy. Generally, we say only about half the patients that we see ever require long-term systemic treatment for their sarcoidosis. Most of you on this webinar are probably in the group that are above that first level, but to keep it in mind that observation and no therapy is a first step in all patients. However, most of the patients that I see and many of the clinics that we'll see are sick enough that we have to think about treatment, usually from the beginning. The next drug on that step up then is prednisone or other glucocorticoid steroids. But prednisone, prednisolone, solumedrol, these are the drugs that most of you have seen as steroids. Next slide. Now, prednisone has a lot of things that are in its favor and a lot of things against it. And I'm going to, as I go along for many of the drugs, I'm going to give you a pro and con. It is the cheapest drug available. It's cheaper than aspirin. It's fast. It usually works within a week or two. And it's really, in a lot of ways, our most reliable drug. I've always kind of felt that if a patient has a problem with sarcoidosis that doesn't get better with enough prednisone, then I need to think about whether this is going to get better. That is, am I dealing with just end-stage scar tissue or something else I'm going to have to treat a different way? So it is a very reliable drug, but it also has a lot of side effects: weight gain, diabetes, high blood pressure, mood swings, difficulty sleeping, things like that. And I've listed this list, but there's quite a bit more, and I could spend a whole hour talking about all the side effects of prednisone. And most patients who have been on prednisone initially do like it, but it becomes a devil's drug. As time goes on, they realize it has more side effects and more problems. And so the patient and the physician are looking for drugs other than prednisone to treat them. But keep in mind, it's not a bad drug to start with. It's really how long you take it and how much you take are the big problems. Next slide. So in the last 15, 20 years, people who've taken care of sarcoidosis have started looking at other drugs besides prednisone. The usual way that I think about it, and most of us think about prednisone, is if we can get the dose down to less than 10 milligrams a day, then the patient can stay on just prednisone alone. That 10 milligrams is made up by the fact that patients on prednisone, 10 milligrams or less is kind of what the body normally makes every day. It makes hydrocortisone the equivalent of 10. And because of that, most of the side effects do start to disappear as you go down. Not everybody reads the book, however. So some patients on 5 milligrams are still having weight gain, still can't sleep at night. And other people on 15 milligrams feel fine, their weight is doing fine, they no longer have the acne, no other problems. So there is an individuality about it. However, in general, if somebody is on more than 10 milligrams, we start looking at another drug. The next big class of drugs are what I call chemotherapy drugs. These are drugs not because you have cancer, but drugs that work by killing some of the inflammation cells. And there's 4 big ones: methotrexate, azathioprine, leflunomide, and mycophenolate. And I'm going to discuss each of these drugs individually, but the idea here is that all 4 of these drugs have been shown to be effective as what we call steroid-sparing, drugs that are an alternative to taking prednisone and work by killing the inflammation cells. They do not have the same side effects as prednisone, but they have their problems too. Next slide. So methotrexate is kind of the pattern drug. It has a very long track record for treatment for sarcoidosis and even longer in other conditions. It's been used for more than 50 years in rheumatoid arthritis to get people off prednisone for their rheumatoid arthritis. We introduced this drug about 30 years ago for sarcoidosis, and over the years, we and other people have shown it's a very safe drug, much less side effects than prednisone, and has minimal risk for infections, things like fungus infection, bacterial infection, as long as you monitor the patient. And really, you have to monitor by getting blood work. You have to get a white count, liver, and kidney function, and we do that about every 2 to 3 months in our clinic. The white count normally is around 6,000 or 7,000. People who are on high-dose chemotherapy for cancer, when they tell people to stay away from everybody, wear a mask and wash your gloves and that sort of thing, if you've had any relative or anyone you know has been on chemotherapy, they say your white cells are way too low. That's less than 500. So remember, you start off normal around 6,000. When we give drugs like methotrexate or these other chemotherapies, we expect to see no more than a 50% drop. That is usually down to about 3,000 or even 2,000 at the lowest. So we usually don't run into those seriously low white counts. But you do need a drop in the white count, and you do have to monitor blood work to be sure the white count doesn't drop. We also monitor liver function because the drug can be toxic to the liver. But if you get blood work on an every 2 to 3 month basis, you can usually identify who can run into troubles, and you can stop the drug long before it's a problem. Remember, this drug's been around for 50 years, and so there are some rules and guidelines about how to monitor for liver damage, how to monitor for white count, developed by the arthritis people, which we have found very effective in sarcoidosis. Another big difficulty with methotrexate is it takes a while to kick in. I usually tell people it takes 6 months. It can work faster than that. Nobody's disappointed. But if you don't have a response by 3 or 4 months, you shouldn't just say it's never going to work. It can take up to 6 months to kick in. And it only works 2/3 of the time. So if you're sitting there at month 3 and wondering why you're no better, you have to realize that you've had to buy into this, but you may end up having to go to a different drug. If you're not seeing a response by 6 or 7 months, then you probably need to look for another drug. Next slide. Now, when I say another drug, the other chemotherapy drugs all work about the same way. So usually we don't just go from one to the next. We do go from one to the next because of side effects. So like leflunomide is a drug used for, was developed by the arthritis people for rheumatoid arthritis. And it is a drug that has less nausea than methotrexate, but otherwise is very similar. It has a very good track record. Again, like methotrexate, less risk for infections. And in fact, we occasionally will give it in combination with the methotrexate for patients that we're trying to get a little bit of a boost. And this was also done by the rheumatoid arthritis people. Again, you have to monitor blood work every 2 to 3 months. Again, it takes about 6 months to kick in. And again, it only works about 2/3 of the time. Next slide. Imuran, or azathioprine, is another class of drugs. This was developed for patients with transplants, new kidney, new liver, new heart. For more than 30 years, this was the drug that people got so they could get off their steroids after their transplant. It has been, over the years, been used in people for many years for their transplant. And in fact, it's been used during pregnancy. So someone had a kidney transplant at age 21. They decided to have a child at age 24. Although it wasn't supported, there were a lot of people that did get pregnant, and what they found was that Imuran during pregnancy does not harm the baby, other than maybe the baby becomes out a little bit smaller, doesn't grow as well, but long-term, no long-term consequences. Much safer than methotrexate, which unfortunately can cause significant problems to the baby. In fact, it's part of the morning after pill, so we don't recommend methotrexate during pregnancy. I still don't recommend Imuran during pregnancy, but if one of my patients is on Imuran and happens to get pregnant, then I'm not nearly as nervous as if they are on methotrexate. It is also a drug that doesn't affect the liver like methotrexate, and so we use it in patients who have significant liver problems from their sarcoid, and it's fairly safe in that regard. It is a little harder on the white cells. You have to monitor the white count a little bit more carefully in patients on the Imuran. It takes still 6 months to kick in. It has more infections, and head-to-head comparisons between methotrexate and Imuran in sarcoidosis and in other conditions, Imuran always comes out a little bit worse because patients have to stop the drug more often because they get infections. And that's partly because the white cells are more likely to go down. It also isn't as tolerated as well. There's more nausea with it. Now, since Imuran is used a lot by transplant doctors, your physician may be much more familiar with using Imuran than, say, methotrexate. As a pulmonologist, they may have used a lot more Imuran during their training, and so this is a drug they may be more familiar with. The Europeans happen to like Imuran more than I do, for example, for sarcoidosis. So there's some experience, but there's not as many trials published on using this drug. The next slide. The last big the cytotoxic drug is a drug called mycophenolate, or CellCept. This is kind of the new person on the block. It's been available for almost 15 years in the transplant population, but it was only about 4 or 5 years ago that it became generally available for non-transplant patients, and only the last 3 years that it went generic. It's still much more expensive than all the other 3 drugs I've given you. In the transplant population, it is less toxic than azathioprine, so they've liked that drug. It's still fairly safe. Like azathioprine, it's been people who have been pregnant have taken this drug, and they've had no particular problems. It can be given to people who are with liver disease. And its major reason why they like it in the transplant population, it's not as hard on the white cells. The white cells are the infection fighters, and so you want to, if you have a low white count, this may be a safe drug to give. However, I have still seen patients on CellCept who drop their white count, so we still recommend they get blood counts every 2 to 3 months. It still takes 6 months to kick in. The biggest problem with CellCep is there are very few studies published on it. The people from Denver published the largest study on the use of CellCep for sarcoidosis. Dr. Nabil Hamza just published this study, and it's a nice study showing that this drug probably works as frequently as the other ones in the group. But again, it's not as much information. We don't know the long term. And so it's a drug to consider, but we don't have as much information. Next slide. So we've moved from the blue. Now we're moving to the red part of the pyramid here. These are the anti-TNF agents, the green, excuse me. We just gave you the anti-metabolites, and now we're moving to the anti-TNF agents. You can see that this is getting to a smaller number of patients who have had it because the majority of patients are going to be either controlled with prednisone alone or prednisone plus methotrexate or a similar sort of drug. Next slide. Well, infliximab is the premier anti-TNF agent. This is a paper that we published in 2001. And I like to show this to people because it really shows how well this drug can work and how it's changed how we think about sarcoidosis. This lady has given her permission to have her picture shown over the years, and she was published the results of these pictures. In any case, on the left is this woman on prednisone, Imuran, thalidomide, a bunch of drugs, and she still had these lesions on her face. This is a condition called lupus pernio. It's quite rare, but if you have it, you can imagine it can be something you'd like to try to get rid of. 2 weeks after her first dose of the drug, infliximab, you can see her skin lesions look pretty well. This is the best she had looked in 15 years. Next slide. 3 months later, this is the best she had looked for many, many years. You can see all the skin lesions have basically gone away. She has a little bit below her left eye for those of you really carefully looking. And she's been that way for almost 12 years on treatment. And we were able to eventually stop the treatment, and she's still been doing well 2 years later. So this drug, infliximab, can be dramatically effective when everything else doesn't work. Next slide. So in sarcoidosis, in the last 10 years, infliximab and to a lesser extent Humira, infliximab, by the way, is Remicade, and Humira or Divilmab have been used to treat patients with what we call refractory sarcoidosis, failing to respond to routine treatments. However, they have problems. The first and most obvious to everyone involved in this is its cost. These drugs are around $5,000 to $10,000 per treatment, and you have to keep taking them. You have to take it, with the infliximab, we give it by vein initially 2 weeks later, then once a month. And so if you tried to stop, you have to keep taking it monthly. If you tried to stop within a year, there's a 90% chance you would relapse. So these drugs have to keep on board. It's not because they keep the disease around. It is that people who are that sick that need these drugs are usually going to be chronic, and they're going to still have the disease for at least a year or two. As time gone on, and more than half my patients eventually get off the drug, but not in the first year or so. So that's the cost. Infliximab also has a problem that it can cause severe allergic reactions. Red, swollen, can't breathe. This occurs while the drug is being given to you. So part of the cost is you have to be watched by a nurse very carefully during the 2 to 3 hours it takes to run in. There are other problems. You're much more likely to get certain infections like reactivation of tuberculosis. So if you had tuberculosis in the past, this drug may not be indicated. Patients with sarcoidosis are often confused, at least initially, with possibly having tuberculosis, so they're usually worked up for that. But still, we're very careful about giving it to anyone who's had a past history of TB. You can also use it for people with bad heart failure. This is based on some studies where they gave it to people with bad heart failure because they thought it would help them, because it helped in mild heart failure. In bad heart failure, it made them worse. So we don't use it there. There also is a concern about an increased risk for cancer. As of now, this increased risk seems to be only for skin cancers. There are other forms of diseases such as Crohn's disease in which this drug is being used, and other cancers have appeared. But in sarcoid and in rheumatoid arthritis, this so far looks like it's only going to be skin cancers. But it's still a relatively new drug, and we're still kind of keeping track on it. The most interesting from a physician point of view is the drug can actually cause something that looks just like sarcoidosis. So this isn't the only answer to for all treatment for patients with sarcoidosis. It is a treatment option, though, for many patients who are failing other treatments. Next slide. Now, the other anti-TNF drug is adilimab, called Humira. And this drug is very similar to Remicade and infliximab, with the exception that it doesn't have the allergic reactions. That is so low a risk. In fact, people just give themselves their treatment at home. And therefore, it's a little less expensive, and some insurance companies will give you the adilimab, but they won't give you the Remicade. However, it doesn't work as rapidly and reliably as the infliximab. So I tend to use it if people have developed reactions to the Remicade, then I will switch them over to the adilimab and maintain them on that drug. And that seems to work, and we have people on that drug that way for years. Next slide. So I'm going to finish up by talking about some of the other agents. What I've given you so far, the first four, especially the green, blue, red, and green, are what are kind of standard therapies that you probably have talked with your physician about or in the back of their mind. But we have some new treatments that are working their way through. Next slide. One of these is rituximab. This is a lady, again, who has given her permission to have her photographs shown to people. She developed severe sarcoidosis, swelling her right eye. The picture that you're looking at on the left on the prednisone is 60 milligrams a day. You can see that she can't open up her eye. She's had biopsies of that showing lots of sarcoidosis. She had a rare condition which made her much higher risk than the general population for developing cancer spontaneously. And because of that, she did not want to take Remicade. So we gave her rituximab, and we were able within 4 months to get her prednisone down. She's now down to about 6 milligrams a day of prednisone. But in the first 4 months, we were able to show improvement. So she's feeling better. She's a little less swollen, but more importantly, she can open her eye completely on that side without any problems. Next slide. So rituximab in general is an option. We did a small study on rituximab with Dr. Nadira Swice from the University of Illinois, Chicago, and we found that overall the drug worked about 50% of the time. And this is patients who have failed other drugs. So it's kind of like Remicade, doesn't work quite as often, but the other big problem is it could take about 3 months to kick in, so it's not as rapid. It is an alternative because it doesn't have some of the risks that Remicade has. For example, we also don't worry about the risk of new tuberculosis coming up. And we've used it in patients who have developed sarcoid-like reactions to Remicade and things. So it's a drug that works differently than Remicade. So that's one option. Another option was developed by Wanda Drake at Vanderbilt University, and some of you may have heard of this regimen called CLEAR. And this is concurrent, meaning taking at the same time 4 antibiotics: Levaquin, ethambutol, azithromycin, and rifabutin, or rifampin. Many of you are probably familiar with Levaquin. It's like Cipro or Avelox. It's an antibiotic we commonly use. Azithromycin is what's in the Z-Pack. So those two are common antibiotics, routine bacteria. Ethambutol and rifabutin are drugs that are used to treat tuberculosis. This combination of these 4 drugs are used to treat funny forms of tuberculosis. In fact, for a funny form of tuberculosis called Mycobacterium avium complex, these 4 antibiotics are used for up to 2 years or longer. So as a combination, they are relatively safe drugs to use. Next slide. Well, the advantage of the CLEAR regimen is, as it's being evolved, it was used for only 8 to 16 weeks. In the studies that have been reported, and there are a couple small studies, both of them run by Wander, showed a prolonged improvement. That is, developing a remission, which she was hopeful would lead to a cure. We don't really know that yet. I'm still reluctant to call it a cure, but I am saying there's a prolonged remission. That is, people felt better for months after they stopped the regimen. This is not a steroid regimen. This is not prednisone or any form of steroids, and it's actually not the traditional immunosuppressive drugs like methotrexate or Remicade. And all 4 of these drugs are very well known, and they've been widely used for many, many years for treatment of things like tuberculosis. So there's no real surprises about them. However, the biggest con is the side effects. If you take 4 antibiotics, any of you taking antibiotics and have to go on a second one or a third one, realize that you start having more and more problems, and you can imagine taking 4 of them. And it's not clear how we would handle that. In tuberculosis, where we're treating for 2 years, we have some time to kind of adjust it and get the antibiotics just the way people can tolerate it. But we're only talking here about 8 to 16 weeks. It's also a regimen so far that's only been used by a couple of centers. We haven't used it very widely. However, there is a large double-blind randomized trial that I'm doing with Dr. Drake and Dr. Dan Culver at the Cleveland Clinic, and at the end of the day, we'll have studied over 130 patients with the CLEAR regimen with pulmonary disease. And so I think in the next year or so, we'll have a lot more information exactly how well this drug works, what to do when you have side effects, and for us, also importantly, how it works. Does it work as killing the cause of sarcoidosis, or is it just acting as a drug combination that reduces inflammation? Several of these antibiotics just reduce inflammation. We know that already. And so they may be acting like a kind of a poor man's prednisone and reducing the inflammation, and the combination may be why patients are better. Next slide. Another combination that's starting to work its way around is called Acthar gel. This is made by a company called Mallinckrodt, Questcor, and I do have funding support, like I do for most of the studies, from Acthar, for doing studies in Acthar gel. It's a very unique drug because, as I mentioned earlier, it's one of the few drugs ever approved for sarcoidosis. It was approved in 1952, long before prednisone was. And because it's been around, we know a lot about its safety profile. The safety profile are basically that of steroids. It seems to work in multiple ways. One way it works is it works by making your body make steroids. But if I gave you a shot of Acthar, you have a bump in your steroid level for about 12 hours, and then it goes back down again. And you don't have to take another shot for about 3 days. So it seems to have less side effects than the steroids. I do still see people get problems with being hyper that day they take their shot. They get swelling and such. But in general, people have done better with it if they are on high doses of prednisone. It has a lot of disadvantages. The reason why it was abandoned in 1956, my slide just went out. I guess there was censoring there. In 1956 was because of the way the drug was being administered. It's IM. You have to give yourself a shot like an insulin shot rather than taking an oral tablet of prednisone, which is much cheaper. And it is very expensive. It is much more expensive than another drug called colchicine, which is another way of taking it, but that colchicine doesn't last very long. And so the drug is significantly more expensive than even the Remicade. However, since it's approved for sarcoidosis, it is something that your insurance company sometimes will have to pay for if they say they'll pay only for drugs approved for this disease. My biggest problem with Acthar gel is I'm still not sure what the dose is, how long we should treat for, and we're doing studies looking at that. And I think in the next couple of years, very much like CLEAR, we'll have a better idea where this drug fits in. Next slide. There are other drugs that have been studied and used. Most of these have been used for conditions other than pulmonary disease or have been used in only a few patients. Plaquenil or hydroxychloroquine is an excellent drug for skin lesions. It can seem to help with fatigue. It helps with kidney stones. It's just not a very good, what I call deep drug. It's not very good for the lungs or the brain or the heart. Thalidomide, we were very interested in this drug a few years ago. It helps with skin lesions, but this is the old thalidomide that used to be an over-the-counter sleeping pill, but then caused all these terrible malformations to babies. When we use it for sarcoid, if we try to increase the dose to help patients, they'll just get too sleepy and constipated. We're just having a paper coming out looking at stem cells for sarcoidosis. This is a very small study, but it's very interesting, and hopefully the company will pursue this further, and so we may have more information down the road. But right now there is no other source of stem cells. There's a person that's advertising on the web that they will give you stem cells if you come to Florida and give them a large amount of money, but that's not the same thing as we're talking about here. There are no other studies for stem cells right now except for the one that has been closed, and we're publishing in the next month or so. Vasoactive intestinal peptide is a protein that's used as a nebulizer. It's been studied by the Germans, and they're going to be doing another study. And again, it's something that's down the road, and the information is not yet available whether it can be useful in sarcoidosis. It has very few side effects, but you have to take a breathing treatment basically every 2 hours. Next slide. So I'd like to just finish up about a little bit of a concept about inflammation versus scarring. Everything I've been talking to you about is inflammation. So imagine this is the hand you have after you burnt or scraped your hand. That's nice, red, and swollen. And I tell you, well, let's just keep it clean, treat any infection, and we're going to minimize the amount of scarring. But I can't tell you how much scar tissue you already have. If you keep that wound and you keep it really dirty, drag it through the dirt and stuff like that, you're going to have a bigger scar. So whenever I see somebody with sarcoid, and they ask, well, is this going to help me in the long run? I said, well, I'm going to try to minimize the amount of scarring you have. But none of the drugs I've told you about are going to help with the scar tissue. They're only going to help with the inflammation. Next slide. So if you have scar tissue as a result of the sarcoidosis, and now we're really talking about the lung scar tissue, and in those of you seeing your x-rays, sometimes your doctor will say you have scarring up here in the top part of your lung. You can get infections in there like bronchitis and pneumonia. And a particular infection that's a problem is aspergillus. That's the black mold that's on bread. And it can hang out in your lung and cause significant bleeding problems. You can also, as a result of the scarring, scar the blood vessels. You can have what's called pulmonary hypertension. And in the last couple of years, we've been very interested in this because we now have a new set of treatments for pulmonary hypertension, which is not the source of today's talk. But I think that you have to realize that scarring can also occur, and that can be the focus of new treatments. Next slide. So in conclusion, keep it in mind that about half the people with sarcoidosis never requires treatment for any prolonged period of time. Only half the people have to require treatment. And of those people, about half of those, so 25% of all patients up front, are going to need to be on long-term, that is more than 2 years of treatment. This is the group that we focused in the last few years the most on because this is the group we're trying to get off prednisone. And we have now a whole bunch of drugs I just described to you as what we call steroid-sparing. But even in that group, some of them are what we call refractory, that even with all the methotrexate, they're still going to need something stronger, and that's where the drugs like Remicade, Humira, rituximab, and maybe the CLEAR protocol are going to fit in. Next slide. I want to acknowledge the people I work with here in Cincinnati. Dr. Lee Slauer happens to be my wife. She's the oncologist, has helped me with a lot of these drugs as we introduced them. We do pulmonary hypertension and eye disease. And I really want to acknowledge the help of my patients because it's really the patients that are doing all the hard lifting here. I come up with the ideas, but they're the ones that have to accept it. And when you're dealing with your doctor, you have to realize that, you are an individual person, and an individual regimen for each person is different. And you have to accept that, and you and the doctor have to work through that. I think that's my last slide, except for telling you about WASOG. Next slide. That's it. I think I have one more slide. Nope, I guess not. Okay. We're open for questions now?
You have your slide up, sorry.
Yeah. So, Ginger, you want to be the moderator for questions, or is someone else going to do that?
I can do that. I just, your slide is up if you wanted to say a couple things about WASOG.
Yeah, I did want to point out that, and we'll leave this up while we're asking questions, WASOG is the World Association of Sarcoid and Other Granulomatous Disease. I would encourage you to go to the website, and the FSR should have a link to WASOG, and WASOG should have a link to the FSR. The WASOG is our side of it. It's the academic side of thing about sarcoidosis, and for those of you that are interested about articles and things about that, if you have the expertise or you want to lead your doctor to it, this is where to go. It gives you a link to our journal, tells you about where the meetings are and stuff like that. In the United States, there's the American Association of Sarcoid and Other Granulomatous Disease. There's a link to that website, which is just starting up. Rich Bernstein is running that. So we're trying to get more information out specifically about sarcoidosis. I like to point out to my patients that although the Foundation for Sarcoidosis Research is not a support group, it's an educational group, and as those of you that have signed in on this realize that education about sarcoidosis is very important, and that's what the FSR's mission is. So, ready for questions.
Great. Okay. Thank you, Dr. Baughman. Again, we've selected, or we're trying to get to all the questions. So if I'm going to read them the way, basically how they're written, so I'm hoping they make sense. The first one is around the main symptoms, or I'm sorry, let me start over. What determines the success of a failure of a drug, for instance, like methotrexate? What determines whether it works or not? Is it relief of pain? And then the second part of that is, if whatever the effect is that is showing success or failure, how long do you try a drug before moving on down the matrix to other options?
Good question. I should have emphasized the fact that we don't treat for an abnormality on the chest X-ray or something like that. We treat for symptoms. Sometimes a blood test got very high calcium or kidney failure would say you have to treat, but most of the time it's for the symptoms. And it's very important to identify which symptoms you're going to be treating for. And so I use that as my target, whatever you're talking about. So you're having cough or you're short of breath. And then the other thing that we're doing is that many of the patients are already on prednisone. So they may be, for example, their cough may be gone away and they may be feeling less short of breath, but they're still on 40 milligrams of prednisone and they're going nuts. So you put them on methotrexate, and over time you try to get them down on the prednisone. So if I can get them down to below that magic 10 milligrams on the methotrexate, even if they're feeling about the same, then I consider that a victory. If they're feeling better, then that's truly a victory. And then I would stay on that regimen for at least, once we get into methotrexate or Imuran, because it's already been there for a year or two, then I usually think about not changing my drugs for about a year to 2 years down the road. And then I would stop and withdraw if they're doing better. If they're doing worse, as I said, I usually give methotrexate, Imuran, drugs like that 6 months before I move on to the next drug. However, if there's a life-threatening problem or organ-threatening, what we consider, so for example, somebody who's going blind or someone who has developed a neurologic problem, they can't move their arm, their leg, and you have to give them very, very high doses of prednisone, and you're still, and every time you move down, things get worse again, or they're getting worse despite prednisone, then I would move on to the next drug, which would be usually infliximab would be the next one I would consider.
Great, thank you. Next question. This says antioxidants have been shown to reduce SSA in the bloodstream. Could this be a benefit to SARC patients?
SSA is serum soluble serum amyloid, which is a possible cause of sarcoidosis. We know that amyloid are just fibers of kind of the scarring thing. They're a very specific one, and we know that they're part of the granuloma reaction. And there are other things that antioxidants have been used for. Caroline Drent was one of probably the person who studied most specifically antioxidants in sarcoidosis, and she didn't really find an overwhelming response. We use a particular antioxidant, N-acetylcysteine, for a long time in patients with pulmonary fibrosis due to other conditions. NAC and acetylcysteine gets into the lung where many other antioxidants go. So if you were going to pursue that, I'd probably use NAC. But the evidence is still pretty weak in that regard.
Great. Next question. Do you have a recommendation, or what are your thoughts on a patient who is a hepatitis B, who is a carrier of the virus? Is methotrexate safe?
Well, I have a hepatologist that I work with. We did a study where we did 100 liver biopsies, and he's very comfortable about using methotrexate in people with potential other liver problems. Hepatitis C is actually a bigger problem than hepatitis B. But even, nowadays, so that we can go over to Imuran or Celsep, or much safer drugs. So I would probably, if there's any question of liver problems, not even with hepatitis C or hepatitis B, I would probably give Imuran. The one thing you have to realize about hepatitis B and hepatitis C is that they can make you more susceptible when we use these stronger drugs like Remicade and especially rituximab. It's somewhat controversial whether you can give Remicade to somebody who has hepatitis B carrier, but there's no question you should not give rituximab for hepatitis B.
Great. The next question is a little more around the epidemiology of the disease. Do you have information on regarding the sarcoidosis occurring within immediate family members, such as children and siblings? What are your thoughts on that?
Yeah, the statistics are there's about a 5% chance if you have sarcoidosis that somebody else in your family will have sarcoidosis. If you're African American, it's a little bit higher. If you're Irish, it's a little bit higher. So as much as 8% or so. This is not like diabetes or high blood pressure, which really run a lot more families, or asthma even. So what we tell people is if you have somebody, however, if somebody in the family is being thought of that they could have sarcoidosis, let's say they have an abnormal chest x-ray or they have inflammation in their eyes and iritis, and they say, well, my brother has sarcoidosis, they're much more likely to have sarcoid as a cause of that just because if they have symptoms like sarcoid than not. If you're worried about a family member having sarcoidosis because, say, they have a cough or chest pain, the chest x-ray still is an excellent screening test, very cost-effective. Most of the time you'll see an abnormality in a chest x-ray.
Great. That leads to the next question. What would you say is currently the best imaging technique to detect the highest number possible of active spots of sarcoidosis?
Okay. The word best is always a charged number because if you're really looking for the term active and inflammation, we use this term active as opposed to inactive. Going back to that swollen red hand I told you, active means to us inflammation, so the things that we could change. So it's easy to do inflammation on the hand or on the skin or in the eyes, much harder on the chest x-ray. PET scanning is the current hot technique, use that advisably, that we think is a really good way of identifying whether there's still inflammation. Because when I look at an x-ray, I'm just looking at shadows. And I can't tell for sure whether the shadows are old or new and whether they're going to change or not until I give drugs like prednisone. However, a PET scan is quite expensive. It has a reasonable amount of radiation, and it's not approved for sarcoidosis. So those of you who've tried to have a PET scan or your physician's tried to get it for you cannot do it. We are doing a study now looking at the value of PET scanning in people with advanced disease and looking at how it changes with therapy in a consecutive sequential area. But I think it's going to be a long time till we can do that routinely. So I do it. I try to get it when people have a question, but routinely don't. So your next question is, what's the next imaging? We used to say CAT scan was of no value. You should just do a chest x-ray and just make assessment for there. We're now getting a sense that CAT scan, there, especially small nodularity, may be very useful predicting who's going to respond or not. But again, there's no consecutive study looking at that.
Great. What is the consensus on whether or not to take vitamin D supplements with sarcoidosis?
I didn't throw my slides in about vitamin D. I gave this little bit of a lecture at the ASTOG meeting in September, so for those of you who heard this before. Vitamin D is a quirky thing in sarcoidosis. When you're taking your vitamin D supplement, you're taking a vitamin D 25. Your body converts that to making it 125. The enzyme that does that is in the kidney. So when you wake up one morning, in the morning, your body says, hey, I need a little more calcium today because I want to make my bones, keep my bones from falling apart. So your kidney revs up, converts what vitamin D you have, and makes more 125. And in the American diet, he wakes up and says, I want some more vitamin D, and it says, hey, I don't have any vitamin D. I can't make any more 125 today, and then I don't have as much calcium in my bloodstream, and so I grab the calcium out of my bones, and that's how you get osteoporosis, simplistically. The problem in sarcoidosis is that the body doesn't have that wake up and I got to make more calcium today. There's an enzyme in the granuloma. It's the same one that's in the kidney, and it's just, in many people, at least 30%, overacting. It's just converting all the vitamin D25 into 125. And so at least 1 out of 10 patients with sarcoid have too much calcium either in their bloodstream or have kidney stones. So we feel in the sarcoid community that you should not take large amounts of vitamin D. There's some question, I know, we have published on this, that if you take too much vitamin D, you can develop high calcium either in the bloodstream or you can get kidney stones. I've had people who decided to take calcium supplements or go out in the sun and develop kidney failure because their blood calcium went too high. So what we advise people is to not only get a vitamin D25, which is the routine one that your doctor is testing, but also to get a 125, which is a little bit more complicated, takes a little bit more time, to really be sure that your 125 is low. 80% of patients with sarcoid will have a low 25. In a study we did of almost 400 patients, only one of those 400 actually had a low 125. So usually you have enough vitamin D.
Great. What is your experience with IVIG treatments for sarcoidosis and small fiber neuropathy that it has caused?
Okay, sarcoidosis hasn't caused the small fiber neuropathy. I think that they're trying to say, not the IVIG. Yeah. Okay. So small fiber neuropathy, I didn't put that in as another complication because I was focusing on pulmonary, but that is a clear-cut complication of sarcoidosis. It is probably a complication of the fibrosis since, for the most part, anti-inflammatory drugs, even Remicade, don't work very well. In our experience with our fatigue and small fiber neuropathy are related, but you can have one without the other. We have a lot more fatigue than we have small fiber neuropathy, but both of them don't really respond well to the anti-inflammatories. There's a report from the Cleveland Clinic about using IVIG, another very expensive regimen, for small fiber neuropathy and related to sarcoid, and they showed some benefit. Our own experience has not been that great with it. My wife, again, the oncologist, Dr. Lauer, uses IVIG for some cancer-related and chemotherapy cancer-related small fiber neuropathy and has a higher success rate. So we know that it can help for small fiber neuropathy, and it's a drug that, if you can get it approved, is worth considering. Small fiber neuropathy can be very debilitating, and right now we have nothing else to offer for that except for pain medicines, gabapentin, things like that to try to make your pain more comfortable. So I always try it, but my success rate isn't that high.
This question is your thoughts on the use of statins in the treatment of sarcoidosis. Is this what are your thoughts on that?
Yeah. Okay. Where this is coming from is the National Institute of Health has been doing a long-standing trial of Joe Fantana and his group there have been doing a long-standing trial of using statins for sarcoidosis and seeing whether it's helpful or not. They're kind of out there on their own about this. No one else has actually done this. The rationale for doing this is statins have been shown to be anti-fibrotic, so preventing some scarring, and there have been a lot of different conditions in which statins have been tried. Statins are what you use for your high cholesterol, things like Zocor and Lipitor. So many people are on it. In our own experience, we have a large number of people on these drugs for their cholesterol who come and see us for their sarcoidosis, and we have not been impressed that the statins have any real difference in the disease. But we haven't studied it prospectively in the careful manner that the group at the NIH is trying to study it. So I think it's one of those things will remain to be seen. It is not a dramatically effective drug, such as, say, prednisone or all the drugs that I've talked about.
Okay. This question is, those of us with extrapulmonary involvement are stuck in an information desert. Please comment on the treatment options. Or does extrapulmonary sarcoidosis follow the same treatment matrix as pulmonary?
No, there's some differences and some similarities. And by the way, for that person, there is, Ginger, we still have the treatment thing on the website, right?
Yes. Yep. So
okay.
Please go to our website.
I would advise you to go to that because with Dr. Dave Moeller and I and Dan Culver and others, we went to some effort to develop some treatment algorithms, not just for pulmonary but for extrapulmonary, to kind of put out the differences. In general, the drugs are the same, but which we use first and where is different. So for people with, say, neurologic disease, we're going to give much more serious drugs earlier. So that's the example where I would give Remicade after, say, only 3 or 4 months. People with eye disease, the ophthalmologists hate prednisone because of the cataracts and glaucoma. So my ophthalmologist, as soon as he starts somebody on drops and knows that they're going to have chronic sarcoid, they send them to me, and we start them on methotrexate earlier in their disease. People with skin lesions are more likely to respond to lower doses of medications, so we use drugs like the Plaquenil as a management thing, and if we use prednisone, we use lower doses. But the one exception to that is that unfortunate lady I showed you with the lupus pernio. That person may end up going on Remicade if nothing else is working in a sooner time. So you're correct that there aren't that many studies for extrapulmonary disease, and that's why there's a dearth of information. But there are studies we've done in some of the conditions in where we tried to look at them. And there are specific recommendations we've made for eye, skin, brain, cardiac, calcium, and pulmonary in the document that Ginger's got on the FSR, and I would recommend you take a look at that. And it is for clinicians, but it's also should be available to you to take a look at. It has the sheets, and you can often take it with your doctor if there's any questions.
Yeah, if you go to the Sarcoidosis or Foundation for Sarcoidosis website, it's under patient resources. It's called the treatment protocol, and you can just download it as a PDF and print it and share it with your doctor. It's also a mobile app, and there's information on there on the website about that. We're getting a little bit down on time, so we got a few more questions here. When is a PET scan indicated if a diagnosis has already been confirmed through a CT scan, a biopsy, etc.?
Again, I find the PET scan, all the comments about cost, and we'll say it's a free world with Obamacare, so we do it. I would still think the PET scan is only going to be as useful when I'm what I call confused. So somebody comes in and they're having still symptoms, and I think they're on a pretty high dose of regimen. Do I want to push harder, or and I can't tell whether they have scar tissue or do they still have active inflammation? That's really a nice place for the PET scan to be done. And so that's, if I could do it, that would be the ideal place to do it. Cardiac PET scan, slightly different test. It's a PET, but they're monitoring, looking for the heart. This is a useful test to look for whether the cardiac, there is in fact cardiac inflammation. MRI and PET scan in the heart are complementary tests, but I think the PET scan really tells you whether they have active inflammation and therefore need more treatment.
Okay. What are your thoughts about ARA290, which has been in trials for neurosarcoidosis?
It's been in trials for ARA290 it's actually been in trial for small fiber neuropathy. And I did not bring that up because I didn't want to set up your hopes too high for those of you who have small fiber neuropathy, which is at least 20% of patients with sarcoids. It is the trial that was just completed by the Cleveland Clinic and the people at Leiden was looking at a dose study. It was only 1 month. I had several of my patients drive all the way up to Cleveland to be part of the trial. We sent them there because we thought it was an important trial. We're hoping that this will lead to a larger study, but it's still not available. The drug is nowhere available anywhere in the world. The preliminary trials that were done before this dose trial were actually quite encouraging. So we're hoping that this will be a drug that will down the road be available. And I think looking at it, it's probably going to be better than IVIG.
Great. And what is your opinion on anti-inflammatory diets? Do they help?
The major anti-inflammatory diet is a gluten-free. I have several of my patients who have gone gluten-free and who feel that they have felt better. They probably have some benefit. I'm always skeptical about this because I think in terms of how I do a study design, and I haven't been able, and I've thought a lot about trying to make a gluten-free diet and then add some gluten to half the people in a little pill, but we just really can't do that anymore. So we don't really have any data about it. I think if you want to try it, I think you should really have a good, accurate diary of your symptoms before and then go gluten-free for a month or two and see what your symptoms are thereafter and see whether there's a real change. That would be the only thing I'd recommend there.
Great. A couple more. What are the symptoms that one would see if they do have scarring of the lungs?
Well, scarring of the lung, the biggest thing that people complain about is recurrent infections, bronchitis. Every time they get a cold, it settles in their chest. It does lead to shortness of breath, and this is the fibrosis. And again, this is something you're seeing on the X-ray. But I point out that you can have scarring in your lungs and feel fine. Your disease doesn't have to be. Your X-ray can look a whole lot worse than you, and that always is the case in sarcoidosis. Some people have very few symptoms and have a pretty ugly-looking chest X-ray. The doctor comes out and says, "Aren't you short of breath?" You say, "No." And you don't have to necessarily get worse over time. So there's a disease called idiopathic pulmonary fibrosis, which is a gradually progressive disease. It sometimes is fatal, whereas sarcoid, scar tissue, can just sit there and be that same way for the next 20 or 30 years.
Okay. Is Plaquenil the only drug used for high calcium levels in kidney stone disease related to sarcoidosis?
No, it's just the easiest and safest one, so it can work. I mean, Plaquenil, the toxicity is minimal, a little bit of nausea, and you have to have an eye examination once a year. It's been out for about 50 years. There aren't any real big surprises as long as you use the lower dose. So I always like to start with it. It doesn't always work, but if it works, you could be on it for 5, 10, 15 years without much of a thought except for a yearly eye examination. That's different than having to put somebody on prednisone or methotrexate because then you have to be monitored more carefully and you have a lot more side effects.
Okay. I think that pretty much wraps up our webinar. We do have a few more questions, but we're unable to fit them all in. Dr. Baughman, did you have any words that you wanted to say to close out?
No, I appreciate you taking the opportunity. Those of you who listen through, appreciate you listening through. If you have any other questions or issues, that's fine. As I said, I would channel, if you have specific things, you maybe try to channel it through the FSR, and they can send perhaps some messages out to me and go from there. I'd also encourage you to take advantage of the Sarcoid Awareness Month and try to keep people aware of it.
Great, thank you. And I'll second that. If you go to the stopsarcoidosis.org website, which is the Foundation's website, you will see a big banner about the National Sarcoidosis Awareness Month, and clicking that will lead you to a landing page with our partner, the Chest Foundation. All sorts of information on there that should be helpful. It may even be helpful for you to share that information with your doctor if that works for you. Sometimes that we find patients are able to bring that stuff in as well. The last thing is really just to keep visiting overall the website and see what's coming up. We like to recruit for trials when we can. We also like to share upcoming studies that might be happening, as well as just information about networking with other patients and getting other resources for all stakeholders, whether you're family, patient, doctor, etc. So again, thank you for everybody who joined. We will be continuing to do more webinars, so hopefully much more each year as we go. And we also are having a patient conference on April 25th here in Chicago, and hopefully we'll be around in some of the other regions of the United States as well. So thank you all.